Mr. Chairman, dear colleagues, first of all, I'd like to thank the Association for giving me the privilege of the floor. So I've been asked to talk about the future of off-pump revascularization. Before giving my talk, I think we've heard that Ben has just said this morning. I don't think we have to polarize this. The relationship between the patient and the surgeon, and for me the most important thing in coronary surgery is the quality of the revascularization, whether you do it on pump or off pump. Now the debate, the controversy of off pump versus on pump goes on since at least 15 to 20 years, and for me there are three main topics. Is first of all the CAN trial. Not a lot of patients, surgeons not really used to the off-pump technique, and they used all stabilization device. Then came the Ruby trial, huge amount of patients, but surgeon totally unexperienced, and moreover they used the endoscopic vein, which has clearly been demonstrated as not a good idea. And finally, for me, the most strongest paper on off-pump versus on-pump is the coronary investigator trial, which has clearly shown not really optimistic results for off-pump surgery. So what I thought, could we say, like the Sex Pistols used to say, United Kingdom, no future, and in this situation for off-pump surgery? Well, let's have a look at this. There is some advantages for off-pump surgery, mainly for the respiratory failure and for the renal insufficiency. But the major drawback of this trial, and it has been shown several times this morning by David Taggart, is the quality of the revascularization with repeat revascularization, mainly with PCIs. Now, when I look at these results, something very surprising for me, who does a lot of off-pump surgery, is the absence of significance in terms of stroke. And I'm really convinced that this population in the off-pump group, they mainly use the old conventional cardiac surgery using multiple side branches with veins to the ascending aorta, and they did not use the non-touch aortic technique. So for me, this is also a major drawback of this paper. Now, I clearly think that off-pump, if it wants to have a future, has to be focused on patients with comorbidities. And as this last paper has shown, patients with renal insufficiency, pulmonary problems, and disease of the aorta. This has already been demonstrated by John Puskas in 2009, showing that if you operate on a patient with no comorbidity, for example, a 50-year-old patient, you can do it off-pump or on-pump. It won't change anything. The results will be completely equal. But if you do patients with a lot of comorbidities, then clearly you will have a significant difference. The problem, and as we already discussed about it this morning, is that if you only do the two patients you have the portion in aorta off-pump during the year, then you will have a disaster. So Krohn has clearly shown in 1 month ago in the GTCVS that there is a significant relationship between the surgical volume and the risk-adjusted mortality. There is a 5% decrease per high volume of op-cap surgery rather than 3% for the on-pump surgery. So if you want to do off-pump surgery in your more sickest patient, then you have to do it systematically in this patient and not 2 times a year. Now, I clearly think that the off-pump will have a future only if it focuses on its weakness. And what are the weaknesses? Well, several times we heard this morning that there were fewer grafts and more revascularization procedure. So I think that we have to focus on the graft strategy. And in my center, we systematically perform a complete revascularization based on the fractional flow reserve measurement. We don't trust anymore the eyeballing, first of all. Secondly, we systematically use 2 mammaries in a Y composite fashion in order not to touch the aorta. So the fractional flow reserve is a measurement done by the ratio between the distal and the proximal pressure. Estimation of the real severity of the stenosis. This has clearly been demonstrated by the FAME trial, and they found a significant benefit of the FFR-guided PCI over the eyeballing-guided PCI. Now, David Taggart, 1 decade ago, already has clearly demonstrated that there is a benefit of bilateral mammary grafting over single mammary grafting for the left coronary side. And I clearly think that there is 3 ways to do this kind of surgery using the 2 mammaries. You can do them in situ or use a Y composite grafting. The first and more commonly used bilateral mammary in situ grafting is to use the left mammary targeted to the LAD and the right mammary behind the aorta through the transverse sinus to the first marginal. The problem with this configuration, there is 2 problems with this configuration. First of all, you only can reach the very proximal marginal, and secondly, you have to use a third or a fourth graft to the right mammary or to the right coronary artery or to the distal marginals. The other in situ configuration is to cross the midline with the right mammary targeted to the LAD and use the left mammary targeted to the marginal. Once again, the problem is that you have to cross the mammary, so in case of redo, you have a highly risk of damaging this right mammary, and secondly, you have to use a third graft to graft the right mammary and even the right coronary artery, or even the distal marginals. So this is the reason why in my center we use in more than 90% of our coronary surgery this configuration, the Y composite grafting, because we think that we can completely revascularize all the myocardium with 2 mammaries, which has been clearly demonstrated as the best conduits to do a coronary surgery, and we don't touch the aorta. Now, some authors have thought that, well, there could not be enough blood from the left mammary to revascularize completely all the myocardium. There is one crucial anastomosis. This is the Y anastomosis, and if you have a technical problem on this anastomosis, you can completely jeopardize all your myocardium revascularization, and finally, there could be some flow competition. So we focused on these problems, and we've done some FFR measurements in the different sites of this configuration. First of all, in the main stem of the left mammary. Then we pushed our FFR catheter to the right mammary targeted to the marginals, and finally to the left mammary targeted to the LAD. And we found that there were no significant FFR difference between the 2 distal branches of this configuration. There is no difference in terms of resistivity between the 2 distal branches of this configuration. So we clearly conclude that the Y-graft configurations allows you an adequate revascularization of the whole left coronary system with an equal distribution of both branches. Now, this sub-study is, in fact, part of the huge randomized trial I've started in 2003. We've compared in 400 patients Y grafting over the in situ grafting, and we've done some angios systematic at 6 months and 3 years. So now I've submitted this paper to the next EACTS. We are at 7 years mean clinical follow-up with mean of 3 years angiographic follow-up, and we did not find any significant difference between the 2 groups in terms of survival, but very interestingly, we found a significant difference between the 2 groups in terms of angina recurrence and in terms of need of repeat revascularization in favor of the Y composite bilateral mammary grafting. This is mainly due to the more PCI needed in the vessel grafted with the vein in the in situ group, because if you use the in situ group, you have to use a 3rd or 4th graft to revascularize the distal marginal and the right coronary artery. So we concluded that the benefit is related to the higher rate of arterial anastomosis present in the Y configuration group. Now, even in older patients or in patients with diseased aorta, we systematically reimplant the vein that we use into the left mammary. So when I say this, usually surgeons just start to scream because it's a drama to reimplant the vein into the mammary. But it clearly works, and we've demonstrated by doing exactly the same measurement. We did some FFR measurement in both distal configuration, and we found that there was also no significant difference in terms of resistivity and in terms of flow between the 2 distal branches. So now, when we operate on patients above 70 years old and when we use a vein rather than the right mammary, we have clearly demonstrated that there is an adequate revascularization of the whole coronary system with an equal distribution. It's an alternative in elderly patients in off-pump surgery. The only thing you have to take care is the LAD lesion. If you don't have a very severe LAD lesion, then if you reimplant the vein into the mammary, you can have some more competition flow. And so in that situation, you systematically reimplant the vein into the aorta. Now, in some cases, you still need a third graft to completely revascularize the myocardium. And so we've done some measurement, some FFR measurement and some flow measurement into the 3 different in situ grafts. And we found that the veins are completely non-resistive. So when you have to use a third arterial graft, and this is mainly the case when you have to revascularize the right coronary artery, we've clearly demonstrated that there is a high correlation between the minimum lumen diameter, so the diameter of the stenosis, and the function of the graft if you use an arterial graft such as the right mammary or the gastroepiporic artery. But as you can see, the blue line is nearly horizontal, meaning that when you use a vein, you can graft whatever you want. It does not matter the degree of the stenosis. You won't have any flow competition, and so the vein will function normally. So today, we will only use this Y composite grafting targeted to the right coronary artery if the stenosis is very severe, so a suboccluded or an occluded right coronary artery. So I can say as a conclusion that off-pump grafting strategy must be complete and linked to the coronary functional lesion stenosis. There should not be any compromise for the technique, but only for the quality of the revascularization. And definitely we think that composite bilateral mammary grafting is the key, not to touch the aorta, to have the best revascularization possible. Of course, if good myocardial revascularization is not possible with the off-pump technique, then you have to convert. You don't have to say, I won't do this distal march or this PLA because it's not reachable in off-pump surgery. As Oscar Wilde used to say, the pure and simple truth is really pure and never simple. And I will finish by this picture that I found in a French newspaper. This is Sarkozy. And Sarkozy, the French guys in France used to say there is no future for Sarkozy, and I certainly don't know if there is no future for off-pump surgery. I thank you for your attention.
Okay, we're running about 10 minutes late, so there's time for a couple of questions, then we'll have a 10-minute coffee break. David, any questions for David? Jenny.
I enjoy your presentation, but something, and I agree with you that on logic, if you don't touch the aorta, it's less likely that you may have a stroke. However, when you got an incidence of stroke of 1%, although it made sense logically, scientifically, it's a complete nonsense. Because in order to prove a difference, you probably need to look at 50,000 patients.
You're completely right. That's why I think when you do patients without any comorbidities, it won't change anything. I think the major benefit of such technique is for patients with disease aorta or a lot of comorbidities. The problem is if you only do this technique in these patients, then we've already talked about that this morning, you won't be good. You have to do it systematically.
If I can just make a comment about using vein grafts from the IMA. I like to think I'm an evidence-based surgeon, but I can think of one case that changed my practice to stop doing that, and it was a 54-year-old private patient on whom I put a mammary to the LAD. It was a moderate-sized mammary and a moderate stenosis in the LAD, and I took a vein graft at that time, so this is maybe 7 or 8 years ago, to a large circumflex with a very tight stenosis, and the patient was extubated, seemed okay initially, and then arrested on the intensive care unit. So we opened him, massaged him, put on a vein graft distal to his mammary artery in the unit, and he kind of survived for about 10 days or so and then died of multi-organ failure. And at post-mortem, all his anastomosis were patent. So the vein anastomosis from the mammary was patent, the mammary to the LAD was patent, and I've absolutely no question he died from a Steele syndrome in his LAD. And from that point of view, again, now that you say that's one case, but that patient died, and I have absolutely no doubt in my mind. So I'm very, very, very cautious about putting vein grafts onto mammaries, particularly when there's a size discrepancy. Question, please.
Hatem Al-Bashir from St. James's Hospital in Dublin. We have seen from most of these presentations that good results with off-pump come with experience. And one of the points on which Professor Taggart criticized the RUPI trial is the limited experience of most of the participants, whereby the inclusion criteria was to have done 20 off-pump cases, and most of them were doing only 7 per year. My question is, what number of cases defines an experienced surgeon? So how many do you have to have done to be labeled as experienced, and how many do you have to do per year to maintain that experience?
Let's first ask Brian, then Gianni, then Ben, and David, and Andrews, right? Because we're all doing it. So
that's a very difficult question to answer. I don't know what the optimal number is, but it's certainly not 7 a year. I would say from a personal experience that I was confident after the first 100 or so. Beyond that, it became easier and easier and easier. However, we were kind of inventing the technique, if I want to call it that, or rather refining it, tweaking it so that it would make it comfortable for us. There's no point in reinventing the wheel. I think most of us who do virtually 100% off pump have got the technique nailed down. So being trained by an experienced high volume center is where we need to be. And I think that learning experience, that gradation upwards, will become much shallower if you're exposed to the right technique from the very beginning.
Jenny?
Yes, I agree entirely. In fact, the main issues here is that established surgeons will not have, and with all due respect, the humility to go and see how to do it and be taught by another surgeon. So the future is only if you can teach the trainees. And this can only happen in places of high volume of pump surgery. I think a few months ago we published our experience of training trainees for 14 years. We trained 16 people. They are all now doing, some in this country, some abroad. When we look at the whole evidence that we had, and we were talking of more than 10,000 operations, there was no difference between operation done by trainees or the most experienced surgeons. And on average, if the training was structured, meaning we start teaching them how to mobilize the heart, how to put the shunt, then they do a lima into the LAD, then they go to the right and finally to the circumflex, you had a situation where by 30 or 40 cases, the registrar or the trainees was becoming independent. And in fact, we had a significant number of these trainees who went then left operating on their own with no difference whatsoever in terms of results.
Thank you. Andrew?
It's a little different in the States because here you tend to move, you tend to move from center to center to get your training. So a younger person could specifically seek out a center where they did a high volume of off-pump surgery. In the States, you're pretty much committed to one place for the duration of your training. And if you just happen to be at a place that does 10% of its bypass surgery off-pump, you're not going to come out of your training well adapted for that technique. And it's a failing in the system.
What about our guests from India? What's your view?
See, we do it pretty much the same way, but since most of our high-volume centers do have an appreciable workload, so to train the patients, to train the trainees as far as the coronary surgery is concerned is not a big challenge. But what we are doing, as I said before, is we are depending more on the simulation and the wet lab techniques right now, because obviously you want to minimize the effects of the learning curve as we may have. So I think a combination of both helps.
Okay, so I'm getting a signal to wind up this session, but let me just say, about 10 years ago, I was at a meeting at the STS, and it was an evening meeting and very popular because it was before off-pump surgery, but people were still all wondering what it was about. And I sat at a panel with 4 or 5 reasonably prominent, well-known North American surgeons. And the chairman said at the end, as we sat there, he said, right, tell me how many cases do you need to do to have done before you're competent at off-pump surgery? And the first person said 20 or 30. The next guy said 20 to 40, and the next guy said 50, and then it came to me, I said, at least 200, and there were gasps in the audience. But I definitely would say that to be trained in off-pump surgery, you've got to have at least, in fact, for that coronary trial in the New England Journal, one of the entry criteria was you had to have done 100 cases off-pump. But I would say that's probably a reasonable figure to have done. But if you're not doing 50% of your coronaries off pump, you're not comfortable, there's something wrong. Because by just natural progression, once you can do the operation, you aim up to about 80, 90%. I don't do big dilated hearts off pump. I can do them technically, but I don't think the patients do so well. But if you're doing 20% of your CABGs off pump, you're not comfortable with the technique. I think on that point we had better end the session. So I'd like to thank all the speakers and particularly the audience for the great interaction. Thanks.